I'm just going to check this. It's going to be cases, so the doctor is going to explain. هذا بيشتغل على البورد. It's supposed to work like that. خليه اوكي خليه يستعمل الموبايل. مناسب الفونت ولا لازم نكبره شوي؟ كبر شوي. طيب يا جماعة السلام عليكم. Can I have your attention? السلام عليكم. Can I have your attention? طيب كيف الأحوال؟ Any questions so far from yesterday or the day before? طيب خليني نشوف one thing. طيب هلا in my first lecture there are a couple of slides just concepts in terms of general thought process in endocrinology. So I want to talk about 3 points وبعدين نبدأ بالcases تبعنا. First of all, endocrinology, we always think about hormone systems at different levels of control. You know this, but just to reiterate, the control of the thyroid gland is typically at a higher level of the pituitary by the hormone TSH, which is under TRH control from the hypothalamus. So whenever we want to dissect where the problem is, we have to have at least 2 levels of testing in order to know, is it primary, is it secondary, where the problem is, okay? So this applies to thyroid hormone, applies to ACTH, applies to gonadal hormones, and many other things. طبعا not everything in endocrinology has those levels of control. Example, calcium control is under what hormone? Parathyroid. So parathyroid is parathyroid. There is nothing superior to it, okay? But that basically is the first concept, that you have to test several levels in certain situations to know where the problem is. Number 2, we do a lot of screening tests, and then we do some confirmatory tests. Example, when we talk about Cushing, what are the screening tests that we discussed? Dexamethasone suppression test, هو 1 milligram. Late night salivary cortisol, 24-hour urine cortisol. Those we call them screening tests. If they are positive, or at least 2 out of 3 are positive, then we move on to confirmation and other things. We talked about, for example, acromegaly. If I have a patient with high IGF-1, but no clear clinical features of acromegaly, I can do a confirmatory test. What test would that be? صح, glucose suppression test. So that's a confirmatory test. If I have somebody with suspicion of primary hyperaldosteronism, نحكي عنها in our next lecture إن شاء الله. Let me skip that لأنه كمان في screening وفي confirmatory. So keep this in mind. حتى when I ask certain questions بالتست وهذا, make sure إنه you know what the gist of the question is. Am I looking for screening test? Well, am I giving you a case of a confirmatory test? So come on, keep that in mind. Okay, this is important. The third concept I'd like to talk about is that we always in endocrinology diagnose problems clinically and biochemically. What does that mean? Yani, the history and physical exam give me a lot of clues, maybe helping me reach a diagnosis in 80% of the cases, just by history and physical exam. I add lab tests to confirm my diagnosis or to rule out other things. Like, what's the role of imaging? Localization, فقط. Typically, I'm saying imaging is not a diagnostic tool. It's just to tell me where the problem is. I know that problem, but I just want to know where the problem is. Example, Cushing syndrome. We took history, we did physical exam, and we have a case of high pretest probability for Cushing. تمام? What should we do next? Screening test, صحيح? وبعدين حكينا على ال ACTH. طب now I know that this is an ACTH dependent Cushing. Now comes the role of imaging. I want to know, where is this coming from? Is it ectopic? Is it pituitary? This is where imaging comes to help. Okay? So أعطيكم مثال آخر كمان. It's a different, but this is in real life. يعني I'm giving you real life examples. I get referrals from our colleagues in family medicine, for example, in the hospital. Somebody with hypercalcemia and high PTH. So what are you guys thinking? Primary hyperparathyroidism. Okay, fine. Now, I almost always get a patient coming to me to the clinic with a system scan, with a neck ultrasound and all that stuff for this problem. But I don't need these. I already know the diagnosis, and I would do these tests only to localize if I'm going to operate on the patient. Not every case of primary hyperparathyroidism needs surgery. So only those cases that I would know, I plan to send for surgery, I would request those imaging studies. I know those imaging studies don't give me the diagnosis. They give me the location. Example, imaging studies might tell me that the parathyroid adenoma is the right inferior gland, and the rest three, the remaining three are not the problem. So the surgeon would only open half of the neck, targeting this lesion, and the surgery will be quick and short. بينما if I don't plan to send the patient for surgery, I don't need localization studies. I already know the diagnosis, and I confirm the diagnosis that this is primary hyperpara. I don't care where it is. Okay? But just keep this in mind. First of all, 3 levels of control in some situations. Number 2, we have screening test and confirmatory test. You have to know what are we discussing or what are we trying to look for. And imaging typically is for localization, not for diagnosis. Okay? Right. I'm gonna bring you today with me to my pituitary clinic. Okay? You guys will be my residents. We're gonna start a case, وبعدين we'll see where you want to go. What kind of visual problem do you think this patient have when the ophthalmologist send her to you? Most likely a visual field problem, most likely. طبعا ما حيرسل لي refractory error ولا حيرسل لي هلا ممكن يرسل لي other scenario unrelated للpituitary. Retinal problems مثلا. لا cataract ما حيرسل لي بس retinal problems related to diabetes محتمل, maybe. He wants my help to control diabetes, but let's assume here it's a visual field problem. Right, and all MRI was done. معلش, excuse the typos. A pituitary MRI showed a cellular lesion, 2.1 centimeter. So now you're getting this patient. The patient is sitting in front of you in the clinic. You greet the patient. What do you want to know? I can show there is no correct or wrong answer. Feel free to say anything. This is a learning environment, okay? So just history. Anybody can ask a question. She doesn't drive, but yeah, she did not notice any problems. How do you ask this question indirectly, Kaman? Sometimes patients who have visual field problems might bump walls that they don't see. Not necessarily مثلا driving. Yeah, she does have a problem with concentration. She bumps into walls sometimes, which is very unusual.
When did this thing start?
Probably 2 months ago.
I'll be asking about the hormone.
Today?
Especially for
Atini, ask. Don't tell me what you want to do. Ask a question.
Weight gain?
Weight gain, no weight gain.
Because we're more likely thinking that it's a pituitary adenoma, and the most common is prolactinoma. But because of her age, she might not have symptoms because of the prolactin.
I like your analysis, but يعني شوف, things do not necessarily happen as a most common problem. يعني I like إنه أنت عم تفكر بالcellular lesion. What is the differential diagnosis of cellular lesion? Cella is cella turcica. This is where the pituitary is. Type cellular lesion. This is what we describe things in MRI. We don't say an adenoma when you describe a feature, يعني a tumor in front of you. This is basically a conclusion. It could be a conclusion. No, this is a pituitary adenoma. Okay, that's diagnosis. But that's why we use cellular lesion. Differential diagnosis from what you learned. What could it be?
Weight loss.
لا, I'm saying this lesion. What could it be? Pituitary adenoma. طيب, what else? Craniopharyngioma. Cyst. طيب, ممكن تكون part of cranial or other things. Yes. Carcinoma. Yeah, but it's very unlikely, as we said. عموما. بس هو هذا carcinoma and metastasis يعني from somewhere else. ممكن تكون yes, some sort of pituitary hemorrhage.
Inflammation.
Inflammatory, what condition causes inflammation? Lymphocytic hypophysitis. طيب. Could be a meningioma. It could be infiltrative disease, although the size is too big for usually infiltrative, but I'll take that. So this is basically يعني what we're, the ballpark, and this is most likely what we're dealing with. And if we want to probabilities, it's an adenoma most likely. Okay, but adenoma, then what do you need to know? You asked about طبعا المريضة جايتنا ب mass effect symptom, صح?
Yes.
What's another mass effect symptom? Headache. We have to ask about headaches. She does have occasional headaches, not very helpful. So a bit of visual field defect, some headache. Then what should we do next? History لسه. We're still in the history phase. خلينا نمسك one axis ونسأل الأسئلة تبعه. Okay. Growth hormone axis. ممتاز. What do you want to know? Pain in your bones. People with acromegaly, for example, do not have pain in their bones. Where is their pain? Joints, and usually it's osteoarthritis, usually. Like,
there's any maybe like your hands are getting bigger or
صح, ممتاز. Have you had to resize your rings for any reason? Have you had to resize your shoes or get bigger shoe size?
Changes in the face.
Have you noticed significant changes in your facial appearance? Yes.
Do you sweat a lot?
Excessive sweating. ممتاز. Very good question. Spontaneous sweating, by the way. These people جالس أمامك بغرفة very nice and يعني cool. They sweat spontaneously. Very important sign. أو feature حتى يعني sign of yes. ما بنسميها lactation, بنسميها galactorrhea. Okay, galactorrhea, I'll take it. Usually more in prolactinomas. But again, we mentioned co-secreting tumors. ممكن يكون growth hormone secreting and prolactin. Fine.
decreased walking.
Huh?
Decreased walking distance.
What does it indicate? growth hormone ايش؟
Muscle secretion.
لا ما بيأثر على walking distance. Excessive water intake? No. What are you thinking of?
The eye.
DI, ممتاز.
You asked about the menstrual cycle.
How old is she? History. حلو. She had regular cycle until 2 years back.
Maybe like signs of high blood sugar because of the growth of the month.
Signs. احنا لسه بالhistory. We're still in the history. ما سألته other questions. How many axes did we cover so far?
Did you see chin?
We covered some of the growth hormone aspect,
Yeah.
mostly acromegaly features, اللي هي excessive growth hormone. We did not cover deficiency. Now you have, remember, any hormone you deal with, you have to يعني ask about excess and deficiency, both. Now we don't know what this is.
Can you ask about like constipation, diarrhea, palpitation?
Yes, and my suggestion to you, امسكوها one axis or all the questions related to that. So مثلا انت you're referring to hypothyroidism, صح? Central hypothyroidism. So constipation, weight gain, edema,
Coldness.
cold intolerance, fatigue.
Stretch marks.
لا ما هي thyroid. Stretch marks وين بنشوفها؟ Cushing. So we're talking about hypothyroidism. Yeah, ممتاز. What else? ها؟
Delay.
يعني some hair loss. ممتاز. طيب flip the coin. يلا.
Diarrhea.
Diarrhea, palpitation, excessive sweating, tremors, weight loss, anxiety. ممتاز. This is how I want you to think. One axis, deficiency, the same axis, excess, and وهكذا. طيب. This patient, عشان ما نطول الموضوع, this patient has no particular features that are worrisome. She just had this incidental finding, some visual field loss, occasional headaches. The rest are perfectly fine in general. نحكي يعني some weight changes وهالكلام هذا. ممتاز. Exam, what do you want to do? حلو. هلا exam, you're gonna learn more about this يعني when you get into the practical part. بس نحن عادة you either think of exam as the same way as we do من ناحية الهرمونز, excess and deficiency, each axis, أو بيكون عندي system. System, I usually start with the hand. I look for signs in the hand for anything related to these things. But طبعا this requires a bit of practice. بعدين I go to the arm, I measure the blood pressure, I look at the reflexes, I go to the face, all the features of the face for acromegaly, for Cushing and other things, supraclavicular fullness, dorsal fat pad. We go to the chest, gynecomastia, for example, in males وهالكلام يعني فالمفروض يكون عندنا systematic approach for these findings. On examination, I would tell you this patient does have stretch marks on her abdomen, which are يعني طبعا شوف الcase, and I'm trying to highlight certain things, but it's not a very coherent case, okay? But we're just trying to highlight certain things. So she does have stretch marks on her abdomen. What would you like to know about those stretch marks?
It's ACT.
طيب.
It's pigmented.
شو يعني pigmented? Hey, what's particular? What stretch marks interest us in this context? They are wide. The stretch mark is wide, تمام, and deep violet or purple in color. These are the stretch marks of Cushing syndrome. مين عنده stretch marks؟ منكم. مو ضروري. We all have stretch marks يا جماعة, okay? واحد كان وزنه عالي نزل وزنه. We do have stretch marks. حتى female pregnant كذا, they do have stretch marks. What is different in these stretch marks? They are pale in color and very thin. So not every stretch mark is a sign for us, okay? So you have to come and be aware of this. I showed you pictures of those angry looking stretch marks. ممتاز. So she does have stretch marks which were related to pregnancy, not something worrisome to us. So overall, reflexes were intact. طبعا visual field test, the proper visual field showed by temporal hemianopsia, no cranial nerve involvement. Chest cardiac exam, abdomen unremarkable, not weak, neurological exam grossly unremarkable. ممتاز. Now, what should we do for this patient? Labs, what are you interested in?
I would say growth hormone.
حلو. Prolactin. طيب, prolactin, I'm gonna give you some numbers. Prolactin is 90, normal less than 24. TSH is 0.2, normal 4 to 4. is 9. Are we missing anything? 1, 2, 3, 4, 5. Okay, so who can analyze this? Hello, prolactinoma. خلينا ناخذ one volunteer ونمسك one axis. مين حيعطيني أول volunteer? Go ahead. You mentioned prolactinoma. How do you analyze this? طيب.
So high types of melanoma, and it's encompassing the other structures, which is why there is a lot of these values are lower than normal.
يعني what's the diagnosis here? ما تقولي بس What about here?
No, this stage is no.
طيب. What about here?
High, so
What does that tell you? Menopause. Yes. What about this?
the hormone is normal. IGF is also normal, so maybe it's
primary.
primary axis.
مين عنده أقوال أخرى؟ Yes.
Prolactin, it's less than 200, does not mean to get to know.
You tell me. You're on the right track. I like where you're going.
Maybe it's a bit of drug induced.
حلو ممتاز. So before we say anything about prolactin, I know that prolactin is elevated, but the way to analyze it, how many causes of hyperprolactinemia did we discuss? يمكن 10. صح? Did we cover those things in our history?
No.
Does this patient have zoster infection of the chest wall? Does this patient have chronic kidney disease? Is this patient pregnant? Unlikely. Is this patient on antipsychotics? You need to ask me these questions. صح؟ لأنه we cannot just look at this number وبعدين come up with conclusions. So we have to run through the list of differential diagnosis for hyperprolactinemia. There are more than 10 causes. تمام? If we don't find any cause from our history, she's not on antipsychotics, she's not having kidney disease, she does not have severe, طبعاً, one might ask me, but Doctor, she's hypothyroid. Severe, what kind of hypothyroidism causes hyperprolactinemia?
Primary.
Typically primary or very severe primary. Is this primary?
No.
What is this secondary? What's primary? What could it be? How would it be different? أيوة, TSH would be very high. TSH might be in primary, for example, might be like 180, 200. تمام؟
There will be pigmentation.
لا ما في pigmentation.
Primary?
ليش pigmentation؟ ولا secondary thyroid عم نحكي. This is thyroid. تمام؟ SPH is different. طيب. ممتاز. So here we have to cover all the differential diagnosis. تمام؟ And then, if nothing, we would say this is probably related to the pituitary. Is this a prolactinoma?
No, no.
Yes.
Because
Who said no? Yalla, explain.
we study in the pathology that the lesion is macro, like the lesion is big. To consider prolactinoma, it must be like 200.
هذا الباثولوجي ولا أنا اللي علمتكم الكلام؟ طيب ماشي الحال هعطيها للباثولوجي. طيب okay, that's true. That's true. The cutoff is 200. What's the tumor size here? It's a macro or a micro? Macro. So if it's a prolactinoma because of a macroadenoma, it should be more than 200. صح? This is not more than 200. So what does it mean? Huh? Stock effect. ممتاز. We talked about stock effect. Explain to us stock effect.
So basically, like the pituitary has a stalk connecting it to the brain. The like for example, prolactin's under tonic inhibition of dopamine. This stalk there's a lesion or a mass for whatever reason. The prolactin will accumulate within the pituitary and start leaking out into the blood.
More accumulate, it will be released. The inhibitory signal is lost.
Yeah, there's no dopamine.
Yeah, so that's stock effect. What's causing it? It's the tumor itself compressing on the stalk. ما عندي inhibition, I would have hyperprolactinemia, but usually does not exceed 200. So this is not a prolactinoma. So it's just stock effect. Yes. مو ضروري. Remember, you can have every variety under the sun. I'm giving you here a scenario. The patient does not have many symptoms. Symptom-wise, okay? You see this in practice. لكن الناس تبعها all over the place. هلا again, this is not a very solid case. I didn't put a lot of thought into it, but we're going in the right direction. تمام? This is what? Central hypothyroidism. Not significant. 3T4 is not too bad. Okay. Does it require treatment? Most likely, definitely. What about this one? How do you interpret this? Remember, أنا عم بستخدم إصبعين، صح؟ ليش عم بستخدم إصبعين؟ I'm not saying you this. How do you explain this? How do you explain this? ليش؟ Related. عندي 2 levels of control, صح? That's why I'm using this. That's why I'm using this. صح؟ Right. So here, who can explain this to me? Or what should we do? Huh? Right. ممتاز. What did I tell you yesterday? في شغلة specific how interesting about the cortisol. Cortisol, if it's too low, I know that there is deficiency. If it's too high, I suspect excess. Like if you wide range of normal or gray zone. تمام? يعني I would tell you here, if I'm going to use any cutoff, I would tell you abnormal AM cortisol would be less than 50. Less than 50 does not require any further testing. What does it tell me if it can less than 50? I have adrenal insufficiency. And looking at the ACTH, what does it tell me?
It's nothing wrong with it. Nothing wrong with it. Well, I mean, secreting one is basically.
نحن عم نحكي عن deficiency. We're talking about deficiency. I have AM cortisol 39.
Yes.
ACTH is حاعطيكم رقم آخر, let's say is 40 مثلا أو 30. What does it tell me? What should the primary be? Very high ACTH, very high ACTH, hyperpigmentation اللي حكيت عنها. Okay, so when I have low cortisol but my ACTH is still within normal, this is what we call inappropriately normal ACTH. لأنه ACTH is supposed to be much higher if the pituitary was able to produce that amount of ACTH. But the pituitary is not able to produce that amount of ACTH. ليش؟ لأنه فيها disease. Okay? I want this to be clear. إذا ما هي clear, let me know عادي. We can go over it again.
Can you repeat it, Doctor?
Sure. حغير الأرقام. شوفوا. ACTH does not have to be 4 for me to call this central hypothyroidism. I can still have ACT. It's a bit of a شوي advanced concept. خلينا نحكي فيه. أعطيكم رقم أسهل شوي. لا ما هي borderline. This is very clearly low. I'm gonna say here مثلا 30. Okay? Now, what do you think of this? What do you think of this now? AM cortisol is less than 50. So I know I have adrenal insufficiency. The question now is what? Primary or secondary? This is normal. One of you would tell me, طب يا دكتور المفروض if this is secondary يعني من pituitary adrenal insufficiency, my ACTH should be below 5. But in reality, it doesn't have to be. لأنه بنسميها inappropriately normal ACTH. لأنه if it was primary يعني المشكلة بالadrenal glands ACTH حيكون بال200 وال400. فهمت علي؟ But this is not primary, this is secondary. Even if it's still within the normal range. If I want to make your life easy, I like ACTH 3. Okay, so that's very clear to you. ACTH is very low, AM cortisol is very low. We're dealing with what? Secondary hypoadrenalism. على فكرة, the same thing goes here. مثال آخر. شوية fun here. نقول 1.4. What's the diagnosis? Secondary, still secondary. Still secondary. What would the TSH be in primary? هتكون what? أعطيني رقم. أعطيك generous شوية. 200, 300, you know, that kind of thing. تمام؟ طيب. Are we good? Yeah.
And AM cortisol less than 50. It indicates it's adrenal insufficiency.
صح.
So it's above 50, it's normal.
لا هاي هلا حاجيك حنرجع السيناريو الأول. I showed you one thing here and I'm gonna ask you another question now. What should we do with this patient? This is another scenario. Tell me what should we do? What's the analysis now? You think this is normal, صح?
Yeah.
حلو. You think this is normal, but this is not enough for me. This is not enough for me. I'll be worried with this patient. I'm going to do something else for this patient now. I need to do something else. I cannot leave the patient with such a big tumor, with almost pan-hypopil stop problem, hypothyroidism, growth hormone deficiency. I need to do something else. This is extra, huh? ممتاز. ACTH stimulation test. ليش؟ I told you إنه في عندي wide range of normal. But you have to know if this patient got stressed for any reason. She got an infection, a road traffic accident, anything of that sort. Is she going to be able to generate enough cortisol to face this problem? This is a life-saving hormone. A life-saving hormone. So I don't want to leave any stone unturned. I cannot say that, خلاص يلا الله معك, you're fine, go. I need to do an ACTH stimulation test for this patient. لأنه the last thing I want is to, لا سمح الله, she goes into acute adrenal crisis when I missed subclinical or subtle adrenal insufficiency. Okay? Again, this is something that we're discussing. It's important for you to learn this. I would not leave this patient alone. I would stimulate her with ACTH. How do you do ACTH stimulation test? You inject ACTH, half an hour and 30 minutes, we get what? A cortisol level. What is normal? What is a normal response? Maybe at 30 minutes, حيكون level 450. At once 60 minutes, حيكون 550. What does it tell me now? Normal. خلاص أنا ارتحت. طمنت. Okay? LH, FSH, estrogen. What does it tell me here? She's menopausal. صح? She's menopausal. Low estrogen, high LH, FSH. If I tell you that her, how do you explain this now? Please three مع بعض, ها? صح. ما هي stock effect. Huh? What idiopathic? لا, it's just hypogonadism. This is hypogonadism. What explains this? ليش عندها hypogonadism?
There's no.
The tumor, it's the tumor itself compressing on what kind of cells? Gonadotropes. ما عندي secretion of gonadotropes. صح؟ This patient إذا كان عمرها 22 and I get the same value هيكون التفسير شوي مختلف. I don't expect the LH FSH in a 22-year-old female to be 60 or 70. شوفوا, when I see high LH and FSH in a postmenopausal female, this is healthy. This is normal response from the pituitary. معناتها the pituitary is able to generate those hormones بشكل طبيعي. Now here I can tell you that the patient has one axis involved, second axis involved, third axis involved. كلهم بسبب ايش؟ The tumor, not the stock effect. Tumor. Stock effect يا جماعة only affects prolactin فقط لا غير. A stock lesion في فرق عندي بين stock effect و stock lesion. Stock effect is compression of the stock بيعطيني hyperprolactinemia فقط. Pure and simple. A stock lesion ممكن يعمل لي DI، ممكن يعمل لي hyperprolactinemia، ممكن يعمل لي hypothyroidism، ممكن يعمل you got it؟ So بس ننتبه للمصطلحات بين stock lesion و stock compression أو stock effect. Okay? طيب growth hormone, what do you think? She has growth hormone deficiency. هم 4 axes مضروبين عند المريضة الآن. What do we call this? Panhypopit, صح? And you would wonder why the patient has no significant symptoms. I remember I told you when a patient has both hypothyroidism and low adrenal, they tolerate this for some reason. يعني ما بيجوا بadrenal crisis أو كذا. يعني they kind of tolerate. They have a little bit of fatigue, but they manage. Okay? Like ممتاز.
Prolactin with growth hormone also for the elderly, it's really hard.
What again? What's the question?
The prolactin and the growth hormone, like the masses. With elderly patients, it's really hard to take essentials from them because of the prolactin or the growth hormone.
طيب ما العلاقة prolactin with growth hormone in this particular case? Hyperprolactinemia in this patient, would we expect that she has galactorrhea مثلا? Maybe yes, maybe no, probably no. تمام. Would she have problems with infertility? Yes, but she's menopausal أصلا يعني, okay? These are the main things يعني for hyperprolactinemia. طيب ممتاز. So now we have this picture of hyperprolactinemia because we know that this is stock effect and the rest of the hormones are deficient. Hello? What should we do next? طبعا احنا we have to look at the pituitary MRI. مظبوط يعني we looked at the pituitary MRI طبعا شو اسمه. What I'm interested in here is you guys tell me what am I interested in? ليش biopsy? Did you hear me talk about a biopsy? لحظة شوي. Did I talk about any biopsies so far? No, we don't do biopsies in pituitary, except very rarely if we don't know what the diagnosis is. So there's absolutely no role for a biopsy. أنا بالكارير تبعي كلها يمكن عملنا 4-5 biopsies of pituitary. So this is not something. MRI, absolutely. We have to have an MRI. Full proper MRI نشوف الريبورت نشوف الصور كلها كده. Very important. تمام? Now, I know that it's a 2.1 centimeter cellular supracellular lesion compressing of the optic chiasm. The stalk is not seen, it's compressed. ما عندي cavernous sinus invasion bilaterally. Good report?
Yes.
Okay. Now, what should we do? Surgery. Before surgery, if you operate on this patient, you're going to kill her. ممتاز. Thank you. Thank you. لازم نعالج المريض أول. Okay. Hormonal replacement. The patient is coming to you with hypothyroidism, central adrenal insufficiency. These need to be treated. I cannot leave them and send them to surgery. Low growth hormone, I don't care. Low gonadotropins, I don't care. Okay, but these are essential. Which is more important than the other? Cortisol. How would I treat her here? I would start her on steroids اليوم وبكره بقول لك تبدا بالثايروكسين. I can do the same at the same time both, but I would tell her clearly take them at the same time. ما تنسي واحد ولا الثاني, so she can do the same. I treated her, I gave her steroids, I gave her levothyroxine. Now I'm happy she can go to surgery after 1 or 2 or 3 weeks of the managed. Yes.
Because You wait for until the cortisol that in the ACT.
لا no طيب ممتاز. Who can answer this question? The question is, would you wait for the cortisol level to go up when you start somebody on steroids? أنا حكيت شوي عن هالموضوع. No.
Depends on how long she been in this situation.
No. ما بيهمني. As long as you start her on steroids, أنا حكيت شغلة امبارح بس you have to keep it in mind. We do not have a good test for steroid adequacy when we replace it. But we have tests to in free T4. Okay, we have tests to ensure that the free T4 is going up معناتها صارت in the normal range. We usually repeat free T4 in 6 to 8 weeks. So I do look for the level of free T4 when I replace someone with thyroxine. But when I replace someone with hydrocortisone, I do not do any further testing. It's all subjective. You make sure that the patient has alleviation of her symptoms لو كان في. No مثلا fatigue, no dizziness, no spontaneous weight loss, that sort of thing. So we don't have a test to tell me that steroid replacement is adequate. We give a weight-based dose and monitor clinically.
Do you double the steroid before the surgery?
حلو كتير. Absolutely. 100%. Yes. Double أو triple حتى. Yes. And we usually give it IV. يعني perioperatively we give it IV. ممتاز. Very good. تمام. Why are we operating on this patient? Visual field problem. Okay, to preserve her vision. حلو كتير. ممتاز. Okay. We took a lot of time here, but it's an interesting يعني case. طيب خلينا نحكي other cases verbally. I have a patient who comes to you with features of Cushing syndrome, history and physical, okay? Features of Cushing syndrome. What test would you be interested in doing now? خلصنا history and physical. Screening test. حلو. I like that you use the word screening test. Thank you. What are the screening tests that you know for Cushing syndrome? حلو. Be specific شوي. Okay, أنت قلت لي dexamethasone. That's true, but partially true. 1 ملغ dexamethasone. ليش عم نقول هالكلام؟ لأنه في عندي يمكن 10 أنواع من dexamethasone suppression test. I have the high dose اللي هو 8 ملغ. I have the 48-hour dexamethasone suppression test. I have the 1 mg overnight dexamethasone suppression. ففي كتير. فخلينا نكون specific. 1 mg overnight dexamethasone suppression test. 24-hour urine cortisol. Late night salivary cortisol. ممتاز. So this patient had 2 tests done only. She had the late night salivary cortisol, which was high. She had 24-hour urine cortisol, which was above the normal range. How do you interpret these results?
Positive.
2 positive screening tests. صح? What should we do? ACTH level. ممتاز. Her ACTH level was ال ACTH level عندي من 5 to 60 صح؟ Her ACTH level was 200.
It's increasing, so it's
It's ACTH dependent.
So there's 2.
What are those 2 possibilities? Ectopic opportunity. ممتاز. Are we all good?
Yes.
What is the most important or the most useful test to do at this stage?
IPSS.
IPSS. ممتاز. Do you guys know what's IPSS?
Yeah.
It's an interventional radiology study that's from the groin all the way to the head, and we measure ACTH level centrally and compare it to peripheral. If it was higher centrally, what does it tell me? Pituitary. If it's equal on both sides, it's ectopic. حصعب عليكم الموضوع شوي. Let's say IPSS was done and showed equal peripheral and central. So now what do you want to do? Just we know it's ectopic, صح? ممتاز. What should we do? حلو. What nuclear scan? Probably في 5000 nuclear scan.
The radioactive conference.
Yes. What you have to tell me what type? Iodine is 0 value. FDG PET. بس عندنا دكتور واحد who believes in it في المستشفى. It's not a very good test. It's good thought. I like it. طيب في شيء اسمه PET gallium. Okay. I don't need you to know this. طيب. It's just for the sake of discussion. في عندي PET scan using gallium. We use it for neuroendocrine tumors, might show us something, okay? Again, this is way beyond, and I'm going a bit beyond just for the sake of discussion. I don't need you to know all of this. ممكن نعمل chest CT, ممكن نعمل abdominal CT. We're looking for any lesions بالlungs, بالpancreas, small intestines, could be neuroendocrine tumor anywhere. تمام? I'll close maybe. Okay, fine. If it was IPSS was positive, meaning IPSS indicated it's a pituitary, what should we do next? MRI صح pituitary MRI. لاحظوا انه الى الان لسه ما عملت MRI كل الكلام والليله والتحاليل ما عملت MRI. I did not do an MRI yet. So now I should do an MRI to localize. ممتاز. So this patient, let's say, has an 8 millimeter right-sided cellular lesion, not invading the cavernous sinus. The stalk is deviated to the left side. Posterior bright spot is preserved. What do you guys infer from this? No DI, صح. It's a microadenoma. What's the chance of surgical cure, you think?
Very high.
High. I wouldn't say very high, but it's high. يعني عم تحكي بين ال 70 وال 80% chance of cure, which is really good. You have to select a very good neurosurgeon who specializes in pituitary surgery. There is a correlation between the number of pituitary surgeries a surgeon does per year and the outcome. The more surgeries, يعني the range of 150 to 200 surgeries per year, the best outcome would be the best outcome. Compared to somebody, for example, 50 pituitary surgeries per year. So I would send my patient to the best. I know I have one chance of cure and I want to use it properly. Okay? حلو كتير. The patient went to surgery. Everything looks fine. She was monitored by the ICU. She went to the floor the next day. Everything looks good. She feels happy. She has nasal packing, which is normal, and they went through the nose. You're the rest on the floor. What test would you order to please me? I'm waiting for a test على أحر من الجمر. So you know me and you want to please me with a test. إذا عملت ACTH test حتعصبني. لا, I'm just kidding. It's not the test that I want. No. What am I interested in? Let's you guys think with me. What am I interested in? ممتاز. Cortisol. Why?
Because the ACTH is not changed until 5 weeks after surgery.
Not really. No. ACTH هيتغير بسرعة. But I'm interested in cortisol ليش? In particular, cortisol.
Because she just finished surgery.
بعدين.
She's in stress, so she need.
No.
It should be increased after surgery.
No. But why am I interested in cortisol? I want to know if she was cured or not. What is an indication of cure for me immediately post-op? A drop in cortisol, day 1, day 2, day 3, day 4. Yeah, this patient had cortisol value of 111 to start with. The next day, after the surgery, her cortisol was 80. Very good. في عندي drop بين 110 111 إلى 80. The day after صار 60. ممتاز. She is cured. I know that she's cured. So now I would do what you suggested. I cannot leave her. I know if I wait for day 3, day 4, day 5, I say below 50. صح؟ هتكون أدري insufficient. So now what should I do? I would go to the patient, congratulate her, your surgery was excellent and you're cured, inshallah. And I would start you now on steroids. Okay? How much steroids? Usually 3 times the usual of standard dose, 3 to 4 times the usual dose. Yeah, the usual replacement is 10 in the morning of hydrocortisone, 5 in the evening. I give those patients 40 and 20. I quadruple the dose. So 40 milligrams of hydrocortisone in the morning, 20 milligrams of hydrocortisone in the evening, 3 months, and then we start gradually tapering to off. I might be able to get to off steroids in 6 months, which is cured. Hello? Right. Any questions? Remember, after surgery, what else should I look for?
The other option.
Everything else. صح. Everything else. Yes, I cured her Cushing, but maybe I induced what? Central hypothyroidism. Maybe I induced ممكن يكون عندها DI. ممكن يكون عندها amenorrhea بسبب إنه she lost part of the normal pituitary. So remember that after any surgery, we start from the beginning. كل اللابs we have to order it. Okay. Another case. شو نعطيكم؟ طيب, a patient comes to you with hyperthyroidism. Okay, clinical features of hyperthyroidism, and you're examining the patient now. You want to know what's the reason, or what are the findings of hyperthyroidism that you see. What are the things you're going to be interested in?
Yes,
Reflexes, breast reflexes. The patient does have a goiter. No exophthalmos. No exophthalmos. ولا pre-tibial myxedema. What's the best test to do? طيب, خليني أسألكم. صح, ممتاز. You're absolutely right. TSH is very important, and also pre-T4, صح? So the patient's TSH, هذا شوي حأطلع ندخل على thyroid lecture تبعكم. The TSH was عندكم TSH? Yeah. So the TSH was 0.005, when free T4 was 90. أنت سألني ممكن هل ممكن تكون جريفز إذا المريض ما عنده exophthalmos ولا عنده treatable myxedema؟
Yes.
Yes, it can be, صح? Not all patients with Graves' disease have proptosis. But all patients with proptosis and hyperthyroidism have Graves' disease. You get the point? Hello. So yes, absolutely. Graves' disease ما زال بالصورة. So it could be Graves, could be toxic nodular, toxic nodular adenoma, or toxic adenoma, toxic multinodular goiter, could be medication induced, could be Hashimoto thyroiditis in a thyroiditis phase, صح? Could it be TSHoma?
No.
ليش؟ ممتاز. هلا if it's as I told you, the free T4 is very high and the TSH is completely suppressed. طيب هذا دخلنا على الثايرويد lecture. What is the best test that you should do for this patient? ممتاز, thyroid uptake. خلاص. هلا now we're gonna reverse the case. You have TSH of هصعب عليكم شوي. TSH of 3 with free T4 90. ليش عملت هيك؟ ها؟ ليش استسلمت؟ It's very easy. Yeah. Secondary. مو ضروري, حكينا نحن we call it inappropriately normal. If your free T4 is very high, you have two scenarios. إما TSH completely suppressed and this is primary. صح؟
Okay.
أو إذا كان very high يكون secondary, صح؟ But when it's inappropriately normal, within the normal range, it's still secondary. Okay? ممتاز. So now what are you interested in doing حاليا؟ MRI. ممتاز. Pituitary MRI. You found a pituitary tumor. لنقول 8 centimeters invading the right Campanian sinus. ما في عندي compression of the optic pads. ما في عندي headache. What should I do?
That's normal.
خلينا نرجع للبيسك rules اللي علمكم اياها. Basic rules.
That's the other.
We tested all the other axes. أحسن. Tested all the other axes. They're fine. They're perfectly fine. ما عندي لا excess ولا deficiency. It's invading, so. مو بس بسبب invasion. This is a functioning tumor. All functioning pituitary tumors need to have surgery. The one exception is prolactinoma. So this patient has to have surgery. Okay? And am I gonna cure her surgery?
No.
No. ليش? Sinus invasion. So من الأول I prepare myself. I cannot cure the patient. I'm gonna debulk the tumors. I cannot cure her. So what do I have in my arsenal behind?
Radiotherapy.
To treat her, what can I use to treat her?
This therapy.
Energy.
Radiotherapy.
لا.
Can you give like medication? Iodine, blocking for today?
What medication do we use؟ حكينا عنها امبارح بأول الليكتشر. What medication do we use for TSHomas which are not cured surgically؟ Somatostatin anadol, octreotide. Okay, موجودة بالlecture. So octreotide should be started on this patient. It might help her or not. يعني we increase dose, but this is the first line treatment. Octreotide. If octreotide was not helpful after 3-6 months, I'm not able to control her. What can I use? I can use radiation therapy. Absolutely. Radiation therapy will take several years to control her condition, and radiation therapy might cause مو cancers, might cause other hormone deficiencies over time. Okay? يعني اليوم she does not have مثلا gonadotropin deficiency. Down the line, she might have it in 4 or 5 years or something like that. So you have to keep tracking those hormones annually. Okay? One last case. طيب هنحكي شوي على البرولاكتينوما. A patient who is 25 has a prolactin level sent to you because of amenorrhea and hyperprolactinemia. She was diagnosed by her gynecologist. Why was she diagnosed? And she missed her period for 2 months. Hello? The gynecologist investigated the patient. She went through the differential diagnosis of hyperprolactinemia. Nothing was there. Prolactin level was 266. If you're going to do a pituitary MRI, what are you going to find?
At least
Is it a macro? ما فيها كلام صح؟ اتفقنا. It will be a macro. طيب. So it is a macro, and when you saw the patient, you found that the patient has visual field defect on examination. She did not complain, but your exam showed it clearly. You did the rest of the hormonal analysis, everything looks fine. She does have a bit of low growth hormone. أو حتى عفوا IGF-1. IGF-1 is a bit on the low side, but the rest are fine. You did an ACTH stimulation test لأنه she was in the gray zone مثل ما حكينا, and she stimulated very nicely. So she does not have any insufficiency. تمام? Now, what should you do with this patient? She does have amenorrhea. حلو, بس now the challenge is she has visual field defect. صح? Should we operate or should we give a medication? Medication, still medication. أنا علمتكم إنه دائما primary go-to is cabergoline in these patients. حتى لو عندي visual field compromise. You need to see this in real life to believe it. Within 10 days, or within I would say 5 days, the patient will come to you saying, I can see better. Okay, so it's a very rapid and impressive result we get usually with cabergoline. So the first time, حتى لو عندي compression of the chiasm, is to have her on cabergoline. Hello? So now I bring her back after 2 weeks. I repeat the formal visual field test for ophthalmology. And I see improvement with visual field تبعها. I repeated prolactin بدل 260 نزل ل 140. What should I do? Continue the medication. It's giving me excellent results. Hello? 3 months down the line, she comes to you very happy with the regular period again. What's her prolactin? It's 12. Okay? 12 طبعا حكينا. So now she's basically having regular period again with controlled prolactin level. The tumor is shrinking, we know it, because of visual field testing. What should I do next? طبعا عملنا الأكسيس, everything looks fine. She still has a bit of growth hormone deficiency. Not very important since she's an adult. ما هعالجها, I'm not going to treat her. The rest is fine. Continue the medication. When should I do the first MRI? Typically 2 years صراحة. ممكن نعملها after 1 year. مو غلط. Okay, I can do it after 1 year just يعني ليطمئن قلبي إنه أتأكد إنه it's shrinking in size. That's good. وبعدين I'll do it in 2 years. Maybe it shrank from, what did you say the size was? 2 centimeters إلى مثلا 9 millimeters. Impressive result. تمام. Typically we don't stop cabergoline in these cases unless the tumor disappears completely, which can happen. Okay. بهالحالات هي بيكون عندي complete cure إن شاء الله. تمام. Okay. Any questions? جميل. طيب خلصنا. يعطيكم العافية.
هذا